Hey guys, welcome back to it. So today we're going to be talking about obsessive compulsive and impulse control disorders, which are very similar to and complement the anxiety-based disorders that we talked about last time. So the definition, unsurprisingly, of obsessive compulsive disorder is obsessions and or compulsions. So that's kind of the first big takeaway for this particular disorder that a lot of people don't really realize is that OCD is defined by the presence of obsessions and or compulsions, so not necessarily both. That being said, about 98 to 99-ish% of folks with OCD do have both, so it is rare to have one or the other, but it is possible and definitely something to be aware of. So what is an obsession? An obsession is a recurrent unwanted thought, urge, or image that causes the person anxiety. So that is one piece. We're talking about something that is happening regularly, consistently, something that's also unwanted in nature. I like to point that out because sometimes we use the word obsessed in a slightly different way to say that you are obsessed with a particular like TV show or sport or some other type of fandom. So it's important to differentiate the idea that those types of passion-based obsessions, quote unquote, are different than the clinical type of obsession that we're talking about here. So these are things that this person does not really want to be thinking about, or urges or images that similarly the person doesn't want to be focusing on. And the end result of the obsession is that the person's feeling anxiety because, again, they're not really wanting to focus in on this particular thing. The most common obsessions are going to be contamination and safety. So contamination would be obsessing about, whether or not you are dirty or things in your home are dirty. And so people with contamination-based obsessions tend to engage in a lot of washing and cleaning behaviors. Safety-based obsessions are going to be obsessions that focus on, whether or not you left the dryer on or the oven on or windows or doors are unlocked or things like that. So a person is just really kind of focused on the security of their surroundings or their home. The next three common obsessions are things that are definitely more common within the community, but maybe a little bit less common to you guys, as contamination and safety end up occupying a good number of OCD examples that we see in the media. So the other three that I want to touch on are aggression, sex, and religion. These tend to kind of come more in the form sometimes of unwanted urges. So a person might share that they frequently feel they have the urge to like jerk their car into oncoming traffic, or they have an urge to grab like a pen or pencil and like stab or harm someone else. It's important to note that those are just urges. And again, they're unwanted in nature. So this isn't a violent person or someone who is, at real risk of, homicidal tendencies or anything like that. These are just unwanted urges. And the urges are actually, because they're unwanted, they tend to be pretty distressing and upsetting to the person because they don't want to be thinking this way. You'll sometimes see these kind of violence-based urges among new parents as well. I was working with a mother not long ago who was, this was her first child, and she was just really anxious after giving birth. And she just kept thinking about, what if I like trip going down the stairs with the baby? Or what if I didn't put the baby into the crib correctly and the baby rolls out? So a lot of her obsessions were thoughts relating to something happening to the baby. And ironically, the thing that kind of perpetuates these thoughts is, again, the fact that this person doesn't really want to be fixated on that thing to begin with. So similarly, we can see people becoming fixated on sex as well. Someone might be thinking a lot about deviant sex acts or something like that, and again, be bothered by the fact that they're thinking that way, which of course just kind of perpetuates the issue. Similarly, a person can become fixated on religion. Typically, that comes in the form of either fixating really strongly about like salvation or damnation and sin. And so compulsions are going to be rigid, repetitive behaviors or mental acts that are aimed at decreasing anxiety. So you can see right there, if we're just looking at the definition of the obsession and the definition of compulsion, that these two complement each other really nicely. Obsessions create anxiety, and then compulsions are aimed at decreasing that anxiety. So again, they kind of go hand in hand, but again, keep in mind that for some people, they may simply have an obsession and do nothing about it, or they might have a compulsion that is addressing anxiety that's kind of coming out of nowhere, but isn't really associated with a particular thought, urge, or image. Another thing to note about compulsions is that we're not just dealing with behaviors, but we're dealing with mental acts as well, which would include things like counting or like mentally rearranging things so that they're more symmetrical. So all compulsions are not necessarily things that we can see. The most common compulsions do kind of complement some of the top obsessions. So we've got cleaning and washing, which obviously are going to complement contamination. We've got checking, which does complement safety. And then we've got other things like counting or ordering, which could complement any of the obsessions. So someone might feel that they have to do things 3 times, like they have to flick lights 3 times and go in and out of a door 3 times. And that is the only way to make sure that they remain pure and chaste or something like that. At the end of the day, we want to make sure that the combination of obsessions and or compulsions is time consuming, and typically we consider this to be about 1 hour a day or more. It is possible to see OCD in children, and so I want to talk for a moment about some of the things that are similar between children with OCD and adults with OCD, and things that are different. One difference is that in the same way that kids can't really articulate what's going on with them in cases of trauma, they similarly may have a difficult time articulating what's going on with them with OCD. So they're not going to be able to tell you that, like, oh, I'm really scared of getting sick, and so that's why I'm, washing my hands for 10 minutes at a time. They just know that washing their hands that amount makes them feel better, and that they feel really anxious if not allowed to follow through on whatever the compulsion is. Common obsessions include cleanliness, order, so similar to what we talked about with adults. Some additional ones include health and illness. Specifically, some kids might get fixated on the idea of sickness and death because this is kind of around the age the kids, might have a pet that died or an older relative that died, or seeing someone get sick. And so that kind of introduces the idea of sickness and death. And so kids can get really fixated on wanting to avoid that and kind of doing various behaviors that in their mind are going to keep them safe or their parents safe or siblings safe or things like that. Also, because kids are entering into school, they're being presented with a lot of dichotomous or black and white kind of thinking. And they're being introduced to a lot of rules around like things to do in the classroom, things to do while like walking in a line down the hallway, or things to do during recess. And, that breaking the rules is bad and following the rules is good. And so some kids can get really wrapped up in that. The idea of bad words and breaking the rules, or things that are unlucky. And then on the other hand, things that are good or lucky or in line with the rules. And so kids can get really fixated along those lines as well. Common compulsions include, again, washing, checking, order. So similar to what we talked about with adults. Some unique compulsions, we might see some perfectionistic academics. And this is not just kind of wanting to do well in school, but this might be like writing and rewriting an assignment to make sure that there aren't any pencil smudges or something like that, something that has nothing to do with the validity of the assignment. So we might see kids kind of really focusing in on small little details like that. Similarly, we can see a fixation on dichotomous preferences. So for instance, if, a child perceives some color or number to be lucky, that might be something that this kid fixates on as a way to keep their family members safe, or to undo the fact that they broke a rule at school that day or something like that. It is important with kids to differentiate between normal rituals and quirkiness and learning, and developmental milestones and, what would be OCD. So be sure that, if a kid gets a new like Lego set and becomes kind of fixated on, you know, putting all the pieces away or not wanting to share or things like that, that, you know, like that's not really OCD. A kid who's learning to brush their teeth for the first time and it's taking like 10 minutes to brush their teeth, like that's not OCD, that's just a kid kind of figuring out how to brush their teeth. Kids will typically kind of linger more on things that are new. And then kind of lose interest. And so it's important to kind of look for patterns. You know, are we permanently seeing that it's taking 15 minutes to brush our teeth? Are we permanently kind of fixating in on the number 3, or is 3 just a new number that we've learned? So kind of look for patterns more with kids too. And if something's really kind of persisting longer than you would think is normal, that might be kind of an indicator that we're tipping over into OCD territory. Some additional things to point out about OCD are that it's chronic and it rarely remits without treatment. That's not to say that it can't remit. It does respond well to treatments that are similar to some of the stuff that we talked about last time with anxiety. But without that type of focus, whether it's through therapy, or I've had people who've kind of on their own figured out the treatment for OCD and have kind of worked it in their own way. But one way or the other, the person has to address the way that they're thinking. And without doing that, OCD is not really going to go away. And one of the reasons for that is because OCD is maintained by really, really strong negative reinforcement. Negative reinforcement is a behavioral term that means that a behavior persists because engaging in that behavior removes something aversive from our environment. So this might sound kind of jargony, but it's really the same thing that happens with buckling your seatbelt and your car's little buckle up alarm. So what happens in that situation is you get into your car, you turn it on, you put it into drive, and it just starts beeping at you if you haven't already buckled your seatbelt. And it's not going to stop beeping until you put your seatbelt on. And so you put your seatbelt on to make the beeping go away. So what that is again, it's negative reinforcement. The beeping is encouraging you to put your seatbelt on again and again to make that annoying thing go away. So we are removing an aversive stimulus, and by removing that stimulus, and that removal is contingent upon a behavior, we're encouraging that behavior to persist. And again, the same thing is really happening with OCD. You've got anxiety, whether that comes from an obsession or it's just kind of latent anxiety. And so what do we do to make that go away? We engage in some type of compulsion. So by counting or watching, we're making that aversive anxiety go away temporarily. And so that's what negative reinforcement is. And again, I like to use kind of the car metaphor to kind of link that idea to something that might be more familiar to you guys. The average age of onset's late adolescence to early adulthood. One thing to recognize when I give average ages of onset is it's not that everybody gets this at this age. This is just typical. So again, I mentioned earlier that you can get OCD as a child. So that doesn't mean that this is the onset date for everybody. I've had, like I mentioned earlier, I've had new parents, particularly new moms, have OCD like symptoms for the first time after having a child. So that's another possible kind of route to onset as well. As I mentioned before, most adults with OCD have both obsessions and compulsions, about 96 to 98%. And overall, the prevalence of OCD is about 2% of adults. So relatively rare, definitely rarer than some of the things that we talked about in our last chapter. And most people with OCD have something else going on. And we will use the word comorbidity to refer to people who have more than one diagnosis. So most people with OCD are comorbid, meaning again, that they are going to be diagnosed with something else, typically another anxiety disorder. Males and females are diagnosed equally in adulthood. However, males have a younger age of onset on average. So males are more likely to be diagnosed in their teenage years, maybe even a little bit younger than that. And females are more likely to be diagnosed a little bit later. But by the time we've reached kind of adulthood, the prevalence rate is about equal. I would suggest pausing to watch Howie Mandel talks about living with OCD. It's about a 10-minute video, but it does a really nice job of highlighting how impairing this diagnosis can be. One of the things that's always jumped out at me most about this particular video is that Howie's money contributes pretty strongly to how he's able to cope with OCD. And so it kind of leaves you to really kind of wonder and imagine how intense OCD can get for people who don't have the luxury and the privilege of being able to use their money to kind of mitigate the effects of OCD. So beyond OCD, there are several other obsessive-compulsive related disorders, or OCRDs. Typically with the OCRDs, we're taking time to specify an obsession and or compulsion. So we are being specific as to what the person is obsessing about, or on the other hand, what the person is either doing or thinking about as a compulsion. So one such example is something called trichotillomania, or TRIC, or TTM are typically ways to abbreviate and kind of refer to it in shorthand. TRIC is basically repetitive hair pulling that's resulting in noticeable hair loss. So in this situation, we are specifying the compulsive behavior that is happening. We're dealing with exclusively hair pulling. Other types of OCRDs include things like hoarding, where people will kind of hang on to relatively useless items as a way to address anxiety. Skin picking is another one, where people will kind of pick and scratch at their skin, and it's very much an anxiety kind of reaction. So the OCRDs have things in common with OCD, and then they also have things that make them separate from OCD, which is why the APA has delineated them as their own diagnoses versus kind of subsuming them under OCD. So some similarities are that we're typically dealing with some type of repetitive behavior. So hoarding, skin picking, hair pulling, those are all behaviors versus mental acts, and they're all repetitive in nature. There's a lack of control. This person doesn't want to be doing this thing, but they feel they have to. They feel compelled to, hence the name compulsion. The behavior is aimed at decreasing anxiety. So the person's wanting to feel better, less anxious. Obsessions may be present. There may be something that this person is fixated on that's driving the hair pulling or skin picking or hoarding, but maybe not. And differences include that pleasure can also be kind of an emotion that's intertwined, versus we don't really see that as much with OCD. So for instance, someone might be picking at their hair because they enjoy the sensation of the hair coming out. Similarly, there might be other negative moods that might precipitate the behaviors as well. So people can pull their hair, pick their skin, or hoard, not just because they're anxious, but because they're angry, they're bored, or they're sad as well. Versus again with OCD, anxiety is kind of the core behavior. Another OCRD I want to introduce you guys to is something called body dysmorphic disorder, sometimes referred to as either body dysmorphia or BDD for short. Body dysmorphia is a preoccupation with one or more perceived deficits or flaws in physical appearance. So the key here is perceived. So these are not objective, really tangible flaws or defects. These are things that this person sees, but that other people aren't really seeing. And that's what this drawing is meant to depict here on the screen. We've got someone who's looking into the mirror and seeing something that is completely different than how they kind of present by themselves. If the person's belief that how they look is really defective or flawed, despite the fact that others are kind of providing differential feedback, we may use the term delusional to refer to them. So this person believes really, really strongly that their nose is hideous and big, even though like other people are like, no, like your nose is great, it's completely normal. But despite all that, they believe really, really strongly in what they're seeing. We would use the term delusional to refer to that intensity of belief. A delusion, which is a concept we'll get to later in the semester, is a false belief that is really rigid in nature, that you can't really kind of argue or talk to this person about what they're thinking or believing. About 50% of adults with BDD and about 60% of teens with BDD have this really rigid, fixed, delusional type. In addition to being preoccupied with a perceived defect or flaw, we're also going to be seeing some type of repetitive ritual, and this can be either behavioral or mental in nature. Behaviors include things like mirror checking, excessive grooming, skin picking. Weirdly enough, you might think that if this person believes they have a defect or flaw, why would they pick their skin? It's because skin picking, as you guys have already kind of learned on the previous slide, emerges as a behavior that can help with anxiety. And in general, people people will just sometimes pick their skin when they are sensitive about the way that they look. You see this a lot with acne, whether or not the acne is associated with BDD, that people are upset about the way that they look, but they are still just kind of picking and in a way kind of making it worse. You might also see camouflaging types of behaviors where a person might get piercings or tattoos or do their makeup in such a way, or wear kind of loud clothing, I guess, to kind of distract other people away from what that person believes the perceived flaw is. We might also see mental acts like constantly comparing others with themselves. So, when they meet a new person or just see a familiar person, the first thing this person may think about is kind of a mental comparison. There may be avoidance. So this person may avoid going out in public or avoid going to the gym or things like that as a way to cope as well. A possible differential diagnosis, meaning a possible diagnosis that is similar that we might want to consider in making this diagnosis, is anorexia. We would only diagnose anorexia, however, if the focus was specifically on the person's body weight or shape versus like their nose or something like that. And if we're seeing some pretty significant restricting behaviors as a consequence. Some additional things to keep in mind with body dysmorphia are that we're dealing with pretty poor insight compared to OCD. So people with OCD are typically aware that they have OCD and that this is what's going on. People with BDD do not have that level of insight. As I mentioned, they really believe that that they have this flaw, and about half of people, that belief is to the delusional level. So they believe that what's wrong with them is that their nose is messed up or that they have this really ugly acne scar. They do not believe that what is going on is mental instead. And so for this reason, they more often seek out physical rather than mental health care services. So if you are thinking about going into healthcare yourself, these are some places where you might see these patients popping up. Primary care, you're going to see them there quite a bit. About 12% of dermatology patients may have BDD and about 16% of plastic surgery patients. So if you're working in one of those areas, this is definitely a diagnosis to become more familiar with. It's also important to note that because this is a mental health diagnosis and not a true kind of physical issue, physical interventions are not going to be effective treatments. So these are going to be people who, if you did go through with a dermatological or plastics type of intervention, these are going to be frequent flyers. A nose job is not going to fix this because, again, what's really going wrong here is something mental. Delusional beliefs can increase suicide risk, so it's really important to assess for how rigid these beliefs are. Common things that people will become concerned about are their skin, their hair, their nose, and their face. Females, in addition, may become fixated on their hips, their weight, and their skin, and males may become more fixated on thinning hair, their genitals, or something called muscle dysmorphia, which is the relative size of their muscles. So again, remember that with all of these are all perceived flaws. So these are not people with actual really tangible flaws. They might be people with mild flaws, but they're definitely blowing them out of proportion in their head. So even with something like muscle dysmorphia, where we have a male who, most often a male, who's believing themselves to be kind of scrawny or small, this isn't how this person actually presents. This person is more likely kind of abnormal, if not maybe above average musculature, but just doesn't really see themselves that way. The prevalence of this is about 2% of adults, so comparable to OCD, and we do see it more common among young people, including college students. So again, I'd recommend pausing this video now to shift over to a video by a guy named Steven. It's called Body Dysmorphia and OCD Have Taken Over My Life. There are 3 different disorders in this video. And so take some time to take note of what those are. It's pretty obvious. The narration kind of highlights it, and the title of the video gives you what 2 of them are. But what I'd really like you guys to think about is, in thinking about these 3 labels that Stephen has and thinking about his presentation, I want you guys to consider whether or not these disorders appear to relate to one another. So are these disorders similar to one another? Are they different? And then I'd also like you to compare and contrast Stephen's presentation with Howie's presentation. And those will be some things that we talk about in class as well. Okay, Last thing is treatment planning. So again, I'd like you guys to do a little bit of work here before we talk about this in class and reveal the answer. But the treatment for OCD and the OCRDs is really similar to the treatment for the anxiety disorders. So knowing this, I'd like you to kind of think about, what do you think the treatment for OCD is? If you had a patient who was fixated on hair pulling, for instance, in the context of TTM, or someone with body dysmorphia, or someone with just plain old OCD, what do you think the treatment would look like? So just spend a few minutes here coming up with a treatment plan, how you might approach one of these situations, and we'll talk about your ideas in class before we're revealing what the treatment plan for OCD really is. All right, that's all I have for you guys. Thanks for joining.